So now I wanted to take a look at some of the research that's out there to help demonstrate the need, and part of the reason I want to do that is make sure that we're setting the context of this group as working in a data-driven environment. So I want to make sure that what we choose to put in the state plan is based on research and need, and not just because it's something that we think we need. So because we're going to have to, as we educate the legislature and the governor's office and other folks about this, we're going to have to back it up with data. So yeah, that's right, we do have data. Okay, so this research that I'm going to be presenting comes from various sources, but the large majority of it comes from the Kansas Health Institute and the work that Emily Meisen-Sebelius, Ivan Williams, and then Catherine Schautz, I can't remember how to pronounce her last name, did. And none of those folks are no longer they're not at the Kansas Health Institute, and so Emily just recently left, but she was able to send me some of their PowerPoint presentations prior to, so the PowerPoint presentations that I'm going to be, or slides I'm going to be showing is because of her and the work that they did. There it goes. Okay, so first off, we're looking at the prevalence of early childhood mental health needs nationally and in Kansas. And so national research shows that somewhere between 7 and 25% of children aged birth to 5 are affected by mental health issues. And if you translate that to population in Kansas, that means it's somewhere between 14,000 and 51,000 that are from birth to 5 with a mental health disorder that affects their daily functioning, development, and school readiness. So this is definitely looking at more of the children who are being affected by more significant mental health issues and not necessarily those that are maybe being identified by screening and could use some preventative care. So those numbers are obviously, the need is greater than what's identified here. And part of what we need to discuss is what's the definition of early childhood mental health and what are some of the issues that we're looking at. So children can be reliably diagnosed as early as 2 years old with mental health issues such as conduct, anxiety, and depressive disorders. And infants under 2 may be identified with problems related to social interaction, self-regulation, and the parent-child relationship. So that's sort of what we're looking at here in this project, is both of those. And then also looking at the defining early childhood mental health. When KHI looked at this, I think they had some challenges in pinning down what is a definition, because early childhood mental health research does not have a common definition amongst all the research that's out there. But one definition they did find that was consistent or could be consistently applied to the majority of the research was this definition that's up there on the screen, is the young child's capacity to experience, regulate, and express emotions, form close and secure relationships, and explore the environment and learn. And all of these capacities will be best accomplished within the context of caregiving environments. And that includes the family, community, and cultural expectations for young children. So developing these capacities is often synonymous with healthy social and emotional development. But one thing to note is that when we're talking about young children, they're developing social skills to get along with others and then developing emotional skills to regulate themselves. So it's the internal and the external going on there. So when KHI put this definition together, it sort of helped them think more broadly than just diagnosable mental health issues, and to address services, or to look at services that address childhood mental health, social and emotional development. So I think for our project, that's key. We're going to be wanting to focus more on, to include services that are focused on prevention and supports for families as early as possible. And so the next slide is looking at, so why focus on early childhood, 0 to 5? And I don't think that any of this is new to anybody in the room here, so I won't spend a whole lot of time on this. But obviously, if you take a look at this graph, if you see, so look at the peer social skills, which is, I think, the blue line, emotional control, which is the pink line, habitual ways of responding, which is the green line, and language, which is the yellow line. So all of those are components of social and emotional development, and they're highly sensitive in the first few years of life. So this means that these are areas that are rapidly growing, and obviously we want to get in there and help address the environmental situation as much as possible so that children can develop as much as possible during those early years. So I had more to say there, but I can see that everybody understands what I'm saying there, and this is not new information for anybody here, which is why you're here. We need you to be here to share that expertise. So part of the research that KHI did was, number one, just kind of an environmental scan. What's out there? So they asked these 4 questions. What types of mental health services exist in Kansas for children aged 0 to 5 and their families? What organizations provide these services and in what areas of the state? How are they funded? And what state-level data exists to better understand the prevalence of mental health issues in early childhood and assess early childhood mental health services in Kansas? So that was their phase 1 of research. And so the goal of that was to provide a descriptive baseline, and they used various research methods. Their literature review included, obviously, peer-reviewed articles, but also included more great literature review as well. The document review included state budgets and existing data sources, program description documentation, and all of that was coded and analyzed. Then they also used key informant interviews. So they interviewed, I think it was 20 individuals in the field of early childhood mental health, and then also the quantitative data analysis. So they looked at various data sources, including Medicaid and CHIP, and then information from what was the state Medicaid mental health managed care organization at the time, Kansas Health Solutions, and then the Kansas Department for Aging and Disability Services. So in that scan, this is a graph that sort of pictures who's involved in providing services. So after reviewing the literature, this is what they found. So it's shown here in Kansas, early childhood programs and mental health organizations are the main groups that provide these early childhood mental health interventions, although child care, health care, and child welfare are also have connections to the service system. Unlike other sectors, there is no one early childhood mental health sector. So the services cross sectors and programs. So early childhood providers are working with this age group and provide a range of services, with mental health being just one aspect of what they do. So Head Start is one of those. And then mental health organizations like community mental health centers and private mental health providers are focused on mental health, but they're not exclusively focused on the age group. So no one organization is focused on that. However, CAME is one of those unique organizations within the state that focuses on early childhood and mental health. And so their capacity and involvement. And you guys, how many counties do you guys have?
Well, we're statewide. We don't have classroom consultation right now.
But your folks that you know that are endorsed, you know how many counties you guys are representing? At the time of this study was conducted, it was in 9 counties. Oh. So I know it's more than that now. Okay. So we'll probably want to take a look at that. So the important thing to note here is that these services are interconnected, and it often takes collaboration between these multiple programs and sectors to provide everything that a child will need. So that makes it difficult for folks. The next chart, I think, will kind of be hard to read, but I gave you guys a copy of it. I think it's on page 5 of the issue brief, or the special report. So this was, at the time, what was available. And so the chart on the left, you see the main statewide or multi-county direct service providers. So you have community mental health centers, early Head Start, parents as teachers, healthy families, Part C, Part B, and then private mental health providers. So that's along the left-hand side. And then as you look at the top, you see the list of services that comprise the early childhood mental health services that KHI was looking at. So there you can see the range of services go from screening, what might be considered to more preventative type services, such as mental health consultation, parent education, social skills training, and then the more intensive interventions such as therapies, crisis, and wraparound services. So the dark blue or the dark boxes indicate that the organization provides the service across multiple communities. The lighter or medium color means they provide it in some locations, but not all the locations in which they provide services. And then the light blue means that they don't provide that specific service. So taking a look at that, I mean, KHI, they found that obviously community mental health centers are going to be able to consistently provide assessments as well as crisis services for this age group, and many of them provide other services to the age group as well. But to the extent which they can serve this age group does vary regionally, and we'll take a look at some of that. We can see that early childhood programs like Early Head Start, Parents with Teachers, and Healthy Families consistently provide parent education and support and social skills, social emotional curriculums to children. And then infant toddler services is an important statewide resource for children with a variety of developmental disabilities, and that has the ability to collaborate with other entities and provide intensive therapies as they're needed in some areas. While this table doesn't address things like waiting lists or regional availability or program criteria, it does give us a big picture of services that are available and who they're provided by, which will be important as we move forward and work on the state plan amendment and help identify and define what qualified providers will be providing those services. So this chart is looking at the regional variation, and this data is just looking at the Medicaid and CHIP use for young children. And I think the important thing to look at is kind of seeing the range and percentages of children within that age range that receive Medicaid and CHIP services. And so what KHI found was there was a 9-fold variation from less than 1% of Medicaid children receiving a mental health service up to 6.5% receiving a mental health service. So statewide, the average is just under 3%. I don't have that, but that is a good question. Yeah. I don't know how many. I'm sure they have that. They have that in the detail of their report. Right. Yeah, thank you. I'm sure they have that. Yeah, in the narrative of their report. So thank you. Take a look at that. So that's looking at the number of children that receive services. The next looks at the type of Medicaid services that were provided. The most common services were psychosocial rehabilitation, at almost 40% there, which for this age of children is likely to be therapeutic preschool service through a community mental health center. You can also see that most of the services that children are receiving are community-based services, meaning that they are the supportive wraparound types of services, including attendant care, case management, and then psychosocial rehabilitation. The important thing to note here is that these community-based services are only provided to children with SED, so meaning that they have a fairly serious diagnosable mental health issue. And these services are provided by community mental health centers. And so since most of these services are provided through the SED waiver, we're kind of looking at the age range between starting at age 4, although children can be served on the waiver younger than that. So there are some exceptions that can be made. So we're probably looking more at the higher age range of the range that we're looking at. Okay, then next they looked at funding. So keep in mind that this is data from 2012 and 2013. So some of this has changed, and I'll try to make note of that as I go through it. Overall, Medicaid and the Children's Initiative Fund are the main state funding sources for these services. So the CIF, or Children's Initiative Fund, is also a main source, or at the time was a main source of funding for early childhood services, particularly for those programs that fall outside of the traditional mental health system. So because of that, KHI thought it would be important to note the governor's proposed budget at the time that they were looking at, so CIF funding for 2012 and 2013. For the 2013 budget, the Early Childhood Block Grant and the Smart Start program, which have traditionally been separate line items within the CIF, were combined. And so both of these programs allocated funds to local community programs, many of which focus on early childhood mental health. And the Early Childhood Block Grant in particular, at the time, funded several major early childhood programs, such as CAME, Healthy Families, Kansas Parents with Teachers Association, the Kansas Head Start Association, and other programs that targeted specifically early childhood mental health. So overall, the combination resulted in about 30% decrease from the previous year. But then we also need to note that after this was looked at, the early childhood block grant funding changed, and several of those organizations no longer receive that funding, because the Kansas Early Learning Collaborative funding ended. Other program funding levels stay the same, like Early Head Start and Infant Toddler Services, which includes Part B and Tiny K, which, as you remember, right now, yeah. Anymore. Okay. Oh, they didn't at all. Oh, okay. All right. Well, that information must have been right then. All righty. But they provide important services, like we mentioned before, with the screening and treatment in many cases. So the last two programs there, the Children's Mental Health Initiative and Family-Centered Systems of Care dollars, funded mental health services for children with SED. And the Family-Centered Systems of Care grant went solely to community mental health centers, and that was eliminated in 2013. But of those children that were served by that grant funding in the year before it was taken out of the budget, there were 361, or about 5% of those who were served were aged 0 to 5 with that funding. So the funding picture looks a little bit different now than what it used to, which identifies we have a need for this. Another study another source of information they looked at was looking at screening and access to services. So KHI did a physician survey, and then they also did a workforce analysis. And we'll go through some of that. So the physician survey, they had a couple research questions. So what, if any, screening is being routinely done to determine if young children and or their families are experiencing mental health issues, social, emotional, developmental delays? And then how often or how involved are physicians in referring and or treating children once the mental health issue has been identified? And then they had some follow-up questions if they answered. And what entities are children and families referred to, and what, if any, barriers exist in identifying, treating, or referring children? And then they also asked what is the perception or the availability of mental health services for young children, which the importance for us in that project is if they have a perception that it doesn't exist, then they're probably not going to be doing something. So what sort of education do we need to be providing people who will be screening? So the goal was to better understand identification, referral, and treatment practices for young children's mental health. And then they did various surveys that were built upon other national surveys that were conducted. So that the information that they found was comparable to other data sources. And just to kind of give a little background as far as why this was important, which I think we all understand, is that many physicians are seeing young children, so There's a critical window development that we need to make sure we get children screened and identified and referred to services. And then what they also found is that mental health concerns are often identified school age or later. So there's a need for more screening and early identification in children. And then, I mean, obviously we understand this piece, but why we want to identify children early so that they can connect children and families to services early, and then that'll have an impact on children's outcomes and mental health, and then also school readiness. So these are the types of conditions that physicians were screening for. So they were looking at differences between pediatricians and family pediatricians. So the blue bar there is our pediatricians, and the yellow bar is family practice physicians. This one was 2011. Yeah. So most physicians do some type of assessment or inquiry for this age group, and they ask about the specific conditions, and most often they're asking about social emotional delays. And then the next most common is autism and behavior management problems. So almost 75% of physicians will inquire about 2 or more of these conditions. So the other ones that are up there are ADD, ADHD, anxiety disorders, depression, and then post-traumatic stress disorder. Next, we're looking at the types of screening tools that they use. So obviously there's a wide range of tools that physicians were using to screen children. And many of those tools were condition-specific, but some of them were more general. And then there was some variation between family practice physicians and pediatricians. So it looks like the majority of folks use the Denver and the InChat. But next was the Connors, and then the ASQSE. And then between 15 and 17% said, I do not use screening instruments or checklists. So.
I'll laugh at that one.
Yeah. Okay. So here's what they found when they did some of the analysis. So if a physician rated themselves as being more likely to use a screening instrument, then they were more likely to inquire about multiple mental health conditions. So, and then if physicians use multiple assessment tools and rated themselves as being more likely to use those tools, they were more likely to refer. So screening behavior obviously leads to looking at more behaviors, asking more questions, and then more referrals, which makes sense. Assessment methods, about half were not using formal screening. And actually the least likely of the types of screening tool was a formal instrument. They also used, the most highly used was the observation or overall impression. Pediatricians and family physicians did not vary much on that question, so it seems like they're all using that. Regardless of the type of assessment method used, more than half estimated that they identified 5% or less of their patients aged 0 to 5 as having a mental health condition. So if you're looking at what the prevalence is on the national research, they're only identifying 7 or 5% when we know somewhere between 7 and 25% should be identified. And so this is significant because physicians who use formal screening instruments were more likely to identify mental health or social emotional concerns. So obviously not everybody is being screened and referred. Next, they looked at the geographical differences for referrals. So they were looking at the differences between rural and urban, and then also some differences between providers. So about 97% of physicians reported referring, and referring they refer to a variety of mental health providers, but they were most likely, as you can see from here, reporting to community mental health centers. And then the rural and urban difference, urban physicians significantly more likely than rural physicians to refer to a private mental health provider, probably because of availability. But KHI didn't look at that. That was just their assumption. And then rural physicians were significantly more likely to refer to a community mental health center than to a private provider. So once again, availability and access in rural versus urban areas. Availability of services and referrals, when they looked at that, urban physicians reported better availability of mental health services in their community. The higher the age, the more available the services, which once again indicates the need for the work that we're going to be doing. And then if a physician reported quality mental health services in their community, they were somewhat more likely to refer, which makes sense. If they thought that the services weren't quality, they weren't going to make a referral. Nearly all Kansas physicians refer, but they were most likely to refer to community mental health centers. And so looking at the types of conditions when they made a referral, once again, blue is our pediatricians and yellow is the family practice physicians. So most likely reason for referral was for autism, and then followed by that is post-traumatic stress disorder and then behavior management problems. But all of them are pretty close. So we also have other social emotional delays, depression, anxiety disorders, and ADD or ADHD. So I don't think any of that's probably a surprise to folks. Barriers to identification, referral, and treatment. They asked physicians several questions about potential barriers to identifying, referring, or treating mental health conditions based on previous survey work that they had done. And then they used the same analysis and tools that were used by national surveys to be able to compare. So the barriers that were discovered were referral-related barriers, so long wait periods, lack of qualified providers to refer to, and then provider training and competence-related barriers, so lack of training or lack of confidence, and that was related to the quality question that they had asked. And then also reimbursement-related related barriers, lack of time and lack of familiarity with the codes. Could be disorder. Mental health condition-related barriers were appropriateness of diagnosis and treatment of young children, so just kind of not being familiar with that. And then barriers, relationships to reported practices. So greater concern about the ability to diagnose and treat conditions led to they were less likely to inquire and treat conditions, more likely to refer. And then higher ratings of availability of quality services for young children meant they were more likely to report referring children. And then urban physicians were somewhat more likely to report inquiring about mental health conditions. And then those that were in solo practice were somewhat less likely to report inquiring about mental health conditions. So it may be people who are in a practice working with other physicians are able to educate one another or maybe have more professional development opportunities, what KHI was looking at. So treatment methods, when they asked about that, most physicians reported that they were not treating children for mental health conditions. If they did treat, they were significantly more likely to treat ADD and ADHD. And then they were also significantly more likely to treat with medication and in-depth counseling if they did treat. So now we're moving to the workforce analysis. and questions. So the questions they asked were how many providers work with children aged 0 to 5, how many children do they work with, and they were looking at different age ranges within the ages 0 to 5, and then where are providers who work with young children located, and what types of services do they provide. So the goal is to better understand the proportion of providers who work with children aged 0 to 5, the types of services they provide to these children, and their county of practice. So they did a survey of mental health providers and then analysis of existing workforce data. So the first one here, that might be kind of hard for folks to see, they're looking at health professional shortage areas. So this is looking at the percentage of counties on the left in health professional shortage areas. So there were 94.3% counties were in the health professional shortage areas for mental health. And then 45.1% on the left-hand side are children aged 0 to 5 were living in health professional shortage areas. And let's see, I think, yeah, this source of data was the Census Bureau. And then information from the Kansas Board of Healing Arts. This map shows the number of child psychiatrists in Kansas. And so yellow means 0. Finney, Riley, Labette, and Wyandotte at the time each had 1. Harvey and Miami County had 2. Sedgwick County had 5. Douglas County had 6. Shawnee had 8. And then the highest was Johnson County with 21. So obviously lack of child psychiatrists, and they're not spread out evenly throughout the state.
So that shows that none of the states that against hospitals might have psychiatrists and stuff, right? Because they don't have to.
Right. Yeah, I think that would be accurate at this time. That was 2012. Yeah. 7 counties. Yeah. And this is specifically child psychiatry. So then they for their mental health providers. Oh no, this is cane data. Sorry. So this is the turn that page too quickly. So this is endorsed early childhood mental health specialist by county, and so this was from 2012. So early childhood professionals, it's kind of these folks are more applicable to the age ranges of children that we're looking for, and also the level of service that we're looking at. But what's not shown here is the level endorsement. This doesn't. Yeah. Yeah.
And we have endorsed folks at some level in 24 counties. Yeah.
Okay. I think the next one is, so mental health provider survey results. So they asked about the age of and number of children served, and then what types of services that were provided. So, so this is the distribution of licensed mental health providers who serve children aged 0 to 5 by region, and the distribution of children aged 0 to 5. So they broke up the Northeast and South Central. So they took out urban locations within those areas. And so Northeast, urban area, it was the most high, followed by South Central, urban area, then Northeast, again, but the non-urban, and then South Central, again, but the non-urban, and then Southwest, Southeast, North Central, and Northwest. So it's very comparable data to what we were looking at before, where out west there's fewer providers and fewer licensed folks providing services. So policy implications for that they found. So birth to 5 is a critical window for intervention. So we've covered that multiple times. Early childhood mental health services exist in a complicated, complex system beyond the traditional mental health sector. And the availability of early childhood mental health services varies regionally. And the most commonly provided Medicaid services are community-based services, primarily provided through community mental health centers, and also most commonly to children identified with SED. All right. So other policy implications they found were need to educate physicians about screening, then also referral, ensure the availability of quality services, and then there needs to be a special focus on access in rural communities, and then a need for cross-system coordination.